Now, these things are, nice when you talk about them, but I think, in any facility to be successful, it is important that both the technical and the clinical team agree that they are going to follow those type of, paradigms. So then you have the simulation process and the patient diagnostic workup. So here's a situation where we know the CT to Hounsfield proton stopping power customized for scanning. The fact that we have a couple of CT scanners, so we look at the workflows that the patient simulation is done, the setup technique, and the setup dependent immobilization devices. You have to develop the systems, how you're going to be immobilizing the patient, and if there's going to be an organ motion, what type of motion management strategies you're going to be using. You're going to use Cine-MR to get a patient-specific motion model, because you cannot really apply the population-based patient motion models as we do in conventional radiation therapy, because the effect of protons, as I said the other day, Monday morning, that it was almost a binary effect, so patients can be affected differently. So you really need to be looking at a patient individually. So having a MR or an access to MR is very important, because if you have a question of a moving target or a moving structures within the patient's body, then you have to look at or assess what type of motion is going to be there in the patient. And then the CT technique, whether you're going to be using a large bore, because as I mentioned, that because of the CT number to Hounsfield conversion uncertainties, that if you are trying to minimize the margins instead of 3.5% to some lower number, then you have to use a very specific imaging protocol to take care of those situations. Here is a situation where the patient diagnosed